In this short presentation, we're going to have a look at how the diode laser can be used to make everyday dentistry easier. I'm Dr. Glenn Vanass, and this is a case that I did today, December 14th, 2009. What you'll find is we're going to show you how a large amalgam on an upper second molar was removed, and how the diode laser was used to retract the tissue when working around amalgams quite easily, and we were able to put in a final restoration that was both aesthetically pleasing, functional, and simple to do because of the use of the laser. The patient is a 30-year-old female with severe chronic pain in all joints that she suffered after a severe car accident. She is immobilized, unable to work right now, and has severe phobia of dentistry, actually. She wishes to have her existing amalgam restorations replaced, and when she came to see me recently as a new patient, she had relatively poor oral hygiene, so this has been significantly improved through a series of hygiene visits and oral hygiene instruction, but we're still a little concerned about her oral hygiene, and I think through some compassionate care and oral hygiene instruction, she's shown significant improvement. Preoperatively, on the left-hand side, you can see that these two molars, the upper right second molar and the upper right first molar, both have existing restorations that are in there, and the patient wished to have them replaced. On the buccal of the second molar, there was a large amalgam restoration as well, and you can see this on the left-hand side, that it's a low mag view, and on the right hand side a higher mag view of the existing buccal restoration, which showed some leakage both subgingivally and also coronally around the superior surface of the amalgam itself. These are typically not easy restorations to replace, and you have to be careful with them, simply because you'll find that they are easy to have leakage and contamination, and not easy to replace with white resins. In this particular case, the patient was anesthetized with one carpio of ultracane and one carpio of marcaine, posterior superior alveolar injection, and also a middle superior alveolar injection were given to anesthetize the tooth and also the labial tissue. No palatal injections were given. Isolite instead of rubber dam was used because the patient has quite a bit of phobia towards all dentistry, particularly the injections, and also from suffering pain, but also the claustrophobia associated with rubber dam, although I prefer to use that. All restorations were removed using an operating microscope at magnifications of between 5 and 13 power, and that's what the video and the still photography was taken of under the operating microscope. The amalgams were removed, all the decay was removed, and the preparations were cleaned, beveled, and acid etched with phosphoric acid. Prime Bond NT was used as the bonding agent, and one shade of Gradia was used for the occlusal surfaces. These are posterior restorations, and given the patient's phobia, I didn't want to have to spend inordinate amounts of time sculpting these restorations and making them a variety of shades. The final restorations on tooth number 17, which is number 2 in the U.S. Numbering system, was an MOB restoration, and tooth 16 was an MODL restoration. Preoperatively, again, we revisit these two teeth, and you can see on the upper right, second molar has an MO, an existing occlusal in the distal pit, and the 16 on the right-hand side, the first molar, has an MO and a DO restoration, with a lingual composite that arises from that DO. You can see here, after the preparations were nearing completion, the state of the existing restorations, and actually surprisingly there was not a profound amount of decay underneath these, and that's why I felt very comfortable replacing them with resins. You can see the final restorations here nearing completion have been placed in the occlusal surface, and you can see that they have a fairly nice blending effect with the enamel and dentin that is present. When we turn to the preparation of the buccal restoration, it had a large amalgam restoration. This was both subgingival, and as mentioned earlier, there was recurrent decay subgingivally and also coronal to the restoration itself. The patient wasn't that happy with the color of it, and because they were missing one premolar, She did notice it when she was smiling and always felt self-conscious about this particular restoration. Eventually, this tooth will need a full coverage restoration once satisfactory oral hygiene is demonstrated at a recall visit and the patient is in better financial shape than she is right now. The laser settings, we use the AMD Picasso diode laser. It was used with an initiated tip. We always use initiated tips when it's in contact, which means that it was carbonized or initiated in cork. The settings that were used were 2.2 watts. It was a pulsed setting at 30 microseconds duration and 30 microseconds interval between the gated pulses. There's little charring and no fear of using the laser around the existing amalgam that was left in. I left a very, very small amount of amalgam at the very end that was close to the gingival margin so as not to nick the margin with the burr. And once the gingival margin of the soft tissue was reduced and pushed away, it gave me access to the final bit of amalgam. Glass ionomer resin was used in this particular case. It wasn't such a concern cosmetically, and as it turned out, it blended in quite nicely. It was GC Fuji 9 that was used. If you look here, you can see again the pre-existing buccal view and higher magnification. And when we were able to remove the restoration on the right-hand side, you can see that there's a little bit of amalgam left, and I was leery of removing this amalgam with the burr in the fear that perhaps gingival tissue would be traumatized and cause a lot of inflammation and bleeding there. Here's a short video of the procedure, and you'll be able to see at high magnification, about 8 times mag, the initiated tip and the diode. I believe this is a 300 micron fiber. We're using a parallel to tooth structure with 2.2 watts pulsed, 30 microseconds on and 30 microseconds off. You can see it's used in small brush-like strokes, very gentle touch to slowly but surely remove the gingival tissue. Some people are concerned about whether perhaps there should be a certain 45-degree angle to initiate a beveled surface, and that's possible if you wish. In this particular instance, what I truly wanted to do was to reduce the level of the gingiva about 1 millimeter or 2 and be able to isolate the gingival margin of the amalgam and therefore be able to have access to removing what was left of it with a high speed without fear of traumatizing the tissue. These are the kinds of things daily that the laser can make your life easier. There's no fear of sparking around the amalgams. There's no fear of the tissue hemorrhaging on you and giving you a problem. You're just able to use a diode very quickly in a matter of a minute and a half and be able to isolate the remaining amalgam and be able to continue on with your restoration. The laser is quick to set up, has a nice return on investment, but really it makes these procedures that would ordinarily be quite difficult to work with fairly simple. And it's unlike an electrosurgery where perhaps you would have the fear of arcing off the metal. You can see in this particular instance that we're able to trim the tissue back, and now we have a great view of the remainder of the amalgam there. When we look at we revisit the buccal preparations beforehand, now you can see it immediately after the diode laser was used. There is two structures subgingival to the amalgam visible, and we were able to remove that without fear of nicking the tissue itself. And then we're able to place a buccal restoration that was allowed to set while we finished the interproximal restorations. And the final view, you'll see in the last picture that the final view is very nice with the buccal restoration replaced in glass ionomer. And we're able to get a very nice aesthetic result with this particular material in this instance. This is Dr. Glenn Van Ass signing off and saying thanks very much, and keep lasing because this is amazing. Thank you.